Thank you, USAID, for empowering me through the training on risk communication and community engagement.
The makeshift teleconsultation services here at Cebu Provincial Hospital, Bogo City is a safe line for men, women, and young girls.
I am cognizant that women and children should be protected from domestic violence, especially this time of pandemic. Thank you, USAID, for supporting this advocacy.
Here, young women and girls are always welcome and never judged for the choices they make.
We are Women for Equal Rights, and we are working hard to provide equal access to healthcare for all Batangians. Thank you, USAID.
We do not allow the pandemic to push back women's use of contraceptives. Thank you, USAID.
We are more equipped to help our community to fight against this COVID-19 pandemic. So I will always be, and our community will always be grateful to USAID.
Realizing the gap of inequitable health services, I feel empowered in creating a change in the healthcare system.
We may be young, but we are our communities, messengers of hope and right information.
The pandemic hit us hard, but we work together as a community to bounce back. Thank you, USAID, for your support.
Thank you, USAID.
Thank you, USAID.
Thank you, USAID. Hashtag choose to challenge.
Thank you, USAID.
Hashtag choose to challenge.
Thank you, USAID.
Hashtag choose to challenge.
Sa ating kolektibong paglaban sa COVID-19, pinakamahalaga ang ating kalusugan. Hindi natin nakikita at walang pinipili kahit sino man ang kalaban natin ito. Ngunit ano nga ba ang ating mga karapatan sa gitna ng pandemyang dulot ng coronavirus? Ako si Ate Cara ng Commission on Human Rights, ang inyong ate na malalapitan kung may tanong kayo tungkol sa inyong karapatan. Kaisa ng pamahalaan ng CHR sa pagpigil at pagsugpo ng pagkalat ng COVID-19 sa Pilipinas. Samahan niyo ako upang alamin kung ano nga ba ang ating mga karapatan sa gitna ng pandemya. Bawat isa sa atin ay may karapatan sa kalusugan or right to health. Karapatan ito sa tinatawag na highest attainable standard of health. Ang karapatan mo sa kalusugan ay nakasaad sa ating konstitusyon at sa mga kasunduang pangkarapatang pantaong nilagdaan ng ating bansa. Ibig sabihin nito, dapat mabigyan tayo ng mga serbisyong pangkalusugan na available, accessible, acceptable, at quality. Hindi natin masisiguro na magiging malusog tayo sa lahat ng oras sa lahat ng panahon. Ngunit, dapat available, accessible, katanggap-tanggap at may mataas na kalidad ang mga health programs para sa atin. Una, available. Mayroon kang karapatan sa sapat at gumaganang public health at healthcare facility. Kagamitan at serbisyo. Ngayong panahon ng COVID-19, ikaw ay may karapatan sa emergency care o agarang lunas laban sa sakit. Kabilang na rin dito ang malinis na tubig, sapat na bilang ng mga sanitation facilities, ospital at clinic, maaasahang medical professionals, at gamot para sa may sakit. Ikalawa, accessible. Mayroon kang karapatan na makamtan o magamit ang mga healthcare facility, kagamitan at serbisyo. Hindi dapat maging mahirap ang pag-access ng mga ito. Kabilang na dito ang karapatan mo sa impormasyong pangkalusugan. Ikatlo, acceptable o katanggap-tanggap. Mayroon kang karapatan sa health programs na akma sa iyong kultura, gender sensitive, at ayon sa medical ethics at confidentiality. Mayroon kang karapatan sa privacy. Hindi dapat isisiwalat sa publiko ang iyong kondisyon, lokasyon, o iba pang personal na impormasyon nang wala mong pahintulot. Ikaapat, quality o mataas na kalidad. Mayroon kang karapatan sa quality medical and health services. Alinsunod dapat ang mga ito sa tamang medical at scientific standards. Ngayong nagsisimula na ang plano ng pamahalaan na i-roll out ang bakuna laban sa COVID-19, iginigiit ng CHR na karapatan ng bawat Pilipino ang magkaroon ng pantay-pantay na akses sa ligtas, epektibo at abot-kayang bakuna. Kaya naman panawagan natin ang Vaccine for All, bakuna para sa lahat. Sa pagsusulong natin sa kampanyang ito, huwag nating kalimutan ang pinaka-marginalized, vulnerable at disadvantaged na mga populasyon sa ating bansa at mabigyang prioridad rin ang iba pang mga balakid na kanilang kinakaharap upang makaiwas at magkaroon ng proteksyon laban sa sakit. Patuloy at sama-sama nating labanan ang sakit na dulot ng COVID-19 habang pinanghahawakan natin ang ating right to health. Para sa mas pinakabagong impormasyon, bisitahin ang CHR social media accounts o ang aming website sa chr.gov.ph. Alam niyo ba? Sa kasaysayan, napigilan na natin ang mabilis at nakamamatay na pagkalat ng polio, tigdas, pulutong, trangkaso, at iba pang mga sakit dahil sa bakuna. Pagkakataon naman natin ngayon na sugpuin ng pagkalat ng COVID-19. Mayroon tayong karapatan sa isang ligtas, epektibo, at abot-kayang bakuna laban sa COVID-19. #Vaccine for all. Bakuna para sa lahat, para sa dignidad ng lahat. Para sa mas pinakabagong impormasyon, bisitahin ang CHR social media accounts o ang aming website sa chr.gov.ph.
Good morning to everyone. We're just going to wait a minute or two more for more participants to join us, but we will get started in just a couple of minutes. Magandang umaga po sa lahat. Okay. Good morning to all of our colleagues and guests. Thank you so much for joining us this morning. We are very excited to have you here with us. As we wait for the roundtable to begin, we are going to literally start on a high note with this beautiful rendition of a well-loved feminist anthem to celebrate Women's Month. I'm proud to introduce to you Rebecca Abraham, one half of Inang Laya or Mother Freedom.
Kayo bang mga Maria Clara, mga huli at mga sisa, na di marunong na lumaban, kaapihay bakit iniluluwa? Mga babae, kayo ba'y sadyang mahina? dahil lalaki ang tanging pag-asa. Kayo nga ba ang mga nena na hanap buhay ang pagkukuha? Mga babae, kayo ba'y sadyang pangkapa? Ang ating isip ay buksan at libon ay pag-aralan. Paano nauubog inyong isipan at tanggapin kayo'y mga libangan? Mga babae, ito nga may kapalaran. Bakit ba mayroong mga Gabriela, mga Teresa at Tanbang Sora na di umasa sa duhat awa? Sila'y nagsipag hawak ng sandata, nagkilaban at ngiti na'y lumaya. Bakit ba mayroong mga Lisa, mga Liliosa at mga Lorena na di natakot makikibaka at ngayon marami ang kasama? Mga babae, ang ngiti na'y lumaya. Ang ating isip ay buksan at libon ay pag-aralan. Paano nahubog inyong isipan at tanggapin kayo'y mga libangan? Mga babae, ito nga may kapalaran. Bakit ba mayroong mga Lisa, mga Liliosa at mga Lorena na di natakot makibaka at ngayon marami ang kasama? Mga babae, ang ngiti na'y lumaya. Mga babae, ang ngiti na'y lumaya.
Thank you so much, Ms. Rebecca Abraham, for that beautiful rendition. I love that song. Thank you so much again, everyone, for joining us. Good morning to you. We're very happy to have you with us today as we start our roundtable discussion, What's Gender Got to Do with COVID-19 Vaccines? With our panel of expert leaders in the field, we're going to be doing a deep dive into the gender equity issues of the COVID-19 vaccination rollout. Before we get started, I'd like to highlight our partners for this event: UNFPA Philippines, the Philippine Commission on Human Rights, the United States Agency for International Development, the WHO, University of the Philippines COVID-19 Task Force, and of course, Spark Philippines. This event has also been organized with the support of the New Zealand Foreign Affairs and Trade, the Department of Health, the Philippine Disaster for Resilience Foundation, Kalinga para sa Kalusugan ng Komunidad, Protection from Sexual Exploitation and Abuse Philippine Task Force, UNICEF, and the embassies in the Philippines of the United States, the Netherlands, Austria, Sweden, the Czech Republic, Great Britain, Germany, and France. Thank you all for your support. We're so excited to hear all the amazing speakers lined up this morning. Before we get started, I'd also just like to remind you of a few housekeeping notes for today. If you are not a speaker, please ensure that your video is off for the duration of the panels today. Please also make sure that you're on mute so as not to disrupt any of the panels. We invite you to use the chat box for any comments or questions as you're listening, and our team will do our best to address these, and we may also have time to pose these to some of the speakers later. We're also live on the Facebook pages of UNFPA Philippines, Spark Philippines, and the YouTube page of the Philippine Disaster Resilience Foundation. And of course, most of our partners are also sharing the live stream on their respective Facebook pages. If you're joining us just now, welcome again to the roundtable on this discussion on gender equity issues of the COVID-19 vaccination rollout. Good morning once again, and we're now going to get started. My apologies, I haven't introduced myself. I am Amina Evangelista Swanepoel. I am the Director of Roots of Health, a reproductive health organization based in Puerto Princesa, Palawan, and I am going to be your host and moderator for this morning's event. Thank you once again for joining us. To formally open our event and discuss the importance of elevating gender equity during the vaccine rollout, I'd like to welcome Ms. Michelle Lang Alyi, the Director of the Office of Health of the USAID. Ms. Michelle has worked for USAID as a health officer for 10 years and has devoted 24 years to the field of international public health. Previously, she served as the director of USAID's health office in Uganda and as the HIV team lead in Cambodia. Prior to joining USAID, she worked throughout Southeast Asia, including the Philippines, with various implementing partners in just about every technical area in the public health field. Ms. Michelle has a background in financial management and public health, specifically international health and development. She has 2 kids who were both born in the Philippines and a husband who's originally from the Philippines as well. Please join me in warmly welcoming Ms. Michelle Lang Alyi.
Good morning, everyone. Magandang umaga po. So first, I'd like to acknowledge the following from the Department of Health, Dr. Noriellen Evangelista from the Disease Prevention and Control Bureau, Mr. Josel Gonzalez, Office of Governor Arlene Bagao, Dinagat Island, Ms. Carolyn Degani, Philippine Federation of the Deaf, Dr. Eunice Melgar, the Executive Director of Likhaan, Bill Luce, Philippine Disaster Resilience Foundation, Chief Resilience Officer, and Dr. Lila Jodain, the UNFPA Country Representative. So welcome to the Philippines. And of course, Dr. Rabi from WHO. Dear colleagues and friends, as a representative of the US government and the United States Agency for International Development, or USAID, I am honored to be here with you all. We have shared unprecedented experiences of battling COVID-19 that has affected our professional and personal lives. A year into the pandemic, I am inspired and in awe that we are stronger, more resilient, and more united in our ongoing work to leverage knowledge, resources, and partnerships for advancing gender equity and gender equality in the context of a COVID-19 response and recovery. So as I look at pictures of last year's memories on social media, I see relatives and friends and colleagues and communities throughout the world remembering what they went through 1 year ago. Laptops were being checked out for work from home, and WFH, an acronym we all started to practice last year. Last minute runs to the grocery store, hurried grab rides to beat the curfew, and of course the halt of field activities, conferences, face-to-face meetings, family get-togethers, birthdays, weddings, and fiestas. It was, as The Economist said, the day the world stopped. As development and humanitarian workers, we know our work cannot stop. By May of last year, USAID was implementing millions of dollars worth of COVID-19 support alongside Philippine partners to support the education, health, environment, governance, business, and the academic sectors. USAID was one of the first partners to respond to the Department of Health's requests for assistance. USAID mobilized to bridge gaps, which included training hospital staff in infection prevention and control, testing and specimen transport, educating health workers and communities on how to prevent getting infected and transmitting the disease, and managing supplies such as distribution of PPE, among others. We also donated 100 state-of-the-art ventilators to 46 priority hospitals across the country. As we worked on universal access to these life-saving interventions, we witnessed firsthand how women and men and girls and boys experience disasters and specifically pandemic differently. We know We now know too well that the COVID-19 pandemic followed the same pattern as previous disasters, where gender-based violence exponentially increased. The impact of COVID-19 on our collective mental health is also alarming. In October last year, USAID, through the Reach Health Project, started to work with Lunas Collective to launch the Family Ligtas campaign, an online campaign against gender-based violence, or GBV, during COVID-19. The campaign generated wide interest and support among 50 journalists and 120 influencers, including broadcast communication celebrities, social media influencers, and showbiz personalities, including 2 former Miss Universe title holders who talked about the advocacy in their own social media accounts. The online campaign has reached more than 3 million people, 68% of whom are women with a median age of 18 to 24 years old. We are delighted to see both women and men, including celebrities, speaking out against GBV. There is no stopping governments, civil societies, and international development partners in amplifying women's voices. On March 8th, International Women's Day, President Biden issued an executive order establishing the White House Gender Policy Council, a body that will instill, advance, and oversee this administration's commitment to a government-wide approach to gender equity and equality. The Gender Policy Council will soon convene key external groups and stakeholders, policymakers, and political leaders, advocates for gender justice and social justice, and academics and experts and leaders in philanthropy and the private sector. 1 year into the pandemic, USAID is monitoring, discussing, and working with the Department of Health and different stakeholders on vaccination strategies and how to best position our assistance. The US government, through USAID, is now by far the largest donor to the COVAX facility, with an initial $2 billion already committed and an additional $2 billion to be provided this year. The COVAX facility will provide approved vaccines to 22 million Filipinos. Globally, and even here in the Philippines, women comprise the majority of the formal and informal health and social care workers, as doctors, nurses, midwives, traditional birth attendants, and community health workers. USAID is committed to harnessing the power of women's energy and leadership to elevate the need of women and girls, particularly those most at risk and vulnerable to the secondary effects of COVID-19. We are pleased to co-convene with UNFPA and others this roundtable because these are important issues that really matter. May this morning's roundtable spark and produce fruitful conversations and planning discussions among duty bearers and right holders to make sure that our continuing efforts emphasize and ensure gender equality and inclusion. In adapting to this new normal, it is more important now than ever to work closely together to ensure that our new normal is the one that is just, equitable, and inclusive. So maraming salamat po. Thank you.
Thank you so much, Ms. Michelle, for those insightful comments and for starting off these important conversations on gender and inclusion. As you noted, if we work hand in hand to make sure that no one is left behind, then our new normal will be more just, more equitable, and more inclusive. And these are just such great ideas for us to remember and to be working towards, and really just sets the tone for this morning. So maraming salamat po. Now, to give us her opening message, I'd like to introduce Dr. Leila Judan, the Philippines country representative of the United Nations Population Fund, or UNFPA. Dr. Leila is new to the Philippines, having just joined the team last February. Dr. Leila worked with the Reproductive Health Center at the National Institute of Family and Population and with the Ministry of Health in Tunisia from 1998 to 2006. Dr. Leila was also the assistant representative at the UNFPA country office in Tunisia for 10 years, where she led the country office's growth in partners and spearheaded the development of the Arab region's first comprehensive law on gender-based violence. Before moving to the Philippines, Dr. Leila was the country representative of UNFPA in Iran for 4 years, where she pushed for the integration of protection and response to gender-based violence. She also advocated investing in youth and women to harness the demographic dividend through a life cycle approach. This morning, Dr. Leila will be discussing some of the main vaccine-related results and recommendations of the Silayan report that UNFPA carried out, which is a gender and inclusion assessment of COVID-19 impacts. She'll highlight specific considerations we have to keep in mind, including the exclusion of hidden households, significant barriers to access, and the escalation of gender-based violence and sexual exploitation and abuse during the pandemic. Please join me in welcoming Dr. Leila Judan to the Philippines and to this panel.
Mapak Palayang Umag. A warm greetings and good morning to all of us here. UNFPA is honored and grateful to be working with our co-conveners, Commission on Human Rights, USAID, WHO, UNICEF, Philippine Disaster Resilience Foundation, Spark Foundation, and University of the Philippine COVID-19 Task Force. I'm really honored to be with you today. And a special thanks to all our esteemed panelists. Please, next slide. UNFPA is a long-time partner of the Philippine government and civil society in advancing 3 strategic and transformative goals, which are first, the ending maternal death, 2, ending unmet need for family planning, and 3, ending GBV and harmful practices to women and girls. In pursuit of these goals, UNFPA works to use demographic intelligence and community-level service delivery projects to address issues of gender equality. From empirical evidence and listening to the most harmed people in marginalized communities, we help shape the strategies that we can use to identify risks and the conditions that worsen the lives of vulnerable women and girls. Particularly those that escalate risks to gender-based violence, the risk of sexual exploitation and abuse is especially alarming during disasters and pandemic. And we need to be ever vigilant in preventing and responding to GBV cases. Today is my first national convening as UNFPA country representative in the Philippines, where I recently arrived. Having been the UNFPA country representative in Iran, I'm used to working in the Middle East with its own set of complex challenges. So I arrived here in the Philippines, ready to roll up my sleeves and get to work. And I was wonderfully surprised to see a long and honored tradition and movement of women's rights advocates, civil society, government agencies, and development partners working hand in hand to address gender equality and women's empowerment. Next slide, please. I'm told that such partnership and collaboration was evident at the onset of the COVID-19 pandemic when 27 agencies came together under the GBV subcluster banner to assess the gender and inclusion dimensions of COVID-19 impact. Coordinated by UNFPA, this assessment was done at the height of the expanded community quarantine. So it was, as Director Michel puts it, when the world stopped. In our assessment, now called the Silayan report and recently released days after the 1-year anniversary of the lockdown, we heard nearly 1,000 stories of how people were struggling and coping with the quarantine measures. Many of these results and recommendations are still relevant to this day. As we pivot to the promise of vaccinations, we need to bear in mind the lessons of 2020 and work to ensure that no one is left behind. There are 3 lessons that we can easily incorporate into our plans for vaccination campaigns. Next slide, please. Lesson 1, we must identify the ways that marginalized communities are being excluded from life-saving support, services, and supplies. There are hidden households who are not recognized because they are not registered voters or members of homeowner association or a teenage mother assumed to be under the supervision of their father. If we know where the holes and gaps are in our safety nets, we can work to remediate and fix them. As we begin the vaccination of more than 17 million Filipinos, it will be easy to miss out on these hidden people and families. We need to ensure that we are not leaving those without internet, without permanent addresses, without childcare, and any other risk factors of our vaccination lists. And as we suspected, vulnerable women and girls across multiple marginalized communities experienced the hardships most acutely. We saw elderly, LGBT, internally displaced communities disproportionately bearing the burden of limited access to transportation, health services, internet, and to water, which became life-saving during this health crisis. Next slide, please. Lesson 2, we must understand the ways that more invisible groups within vulnerable communities are impacted and the harm they experience. Even within the category of women, different kinds of women experience the pandemic uniquely and disproportionately. We saw in the Likhaan report that even as there was a gold rush to online and social media formats, many communities have no internet or have low telecom signal. As we design our vaccination outreach strategies, we need to understand that there will be people who will not even see the online messages, cannot understand our advisories or access our service points. How do we reach them and communicate vital information in ways they truly understand and act on? This is a very important question. Next slide, please. Lesson 3, we saw in the report that the risk to GBV escalated unacceptably. Now more than ever, GBV services must remain open with sufficient staffing and funding to provide essential and life-saving services throughout vaccination processes. We must assume, even when we do not yet have the data and reports, that there will be unscrupulous persons who will exploit this pandemic and ask for sexual favors in exchange for the COVID-19 vaccine. We must ensure that policies and interagency community-based complaint mechanisms are in place for protection from sexual exploitation and abuse in every deployment and vaccination plan for COVID-19 vaccines. It is with these lessons and reminders that UNFPA came to co-convene and co-conceptualize this roundtable with our strategic partners, so that the powerful stories and wisdom we were entrusted with by the most vulnerable communities members who emotionally shared their plight with us are not lost on all of us who carry a collective responsibility to end this pandemic. As was our experience on conducting this gender assessment and co-writing the report, We have no doubt that when Filipino stakeholders put their minds, hearts, and hands on it, they will rise to the occasion and take this matter seriously. That we will move from rhetoric to reality because lives depend on it. During this Women's Month, we hope this roundtable will showcase the strategic thinking, hard-working efforts, and principled leadership of women's rights champions and our allies in centering equity and inclusion in our next steps toward recovery and restoration from this dreadful pandemic. My last slide. Thank you all for your presence and participation, and to our co-conveners who helped turn an idea into a real event. Maraming salamat.
Right. Maraming salamat po. Thank you, Dr. Leila, for the incredibly important points that you just raised. As you noted, women have been uniquely and disproportionately affected by COVID, and you highlighted people who might be excluded and from getting the vaccines, from the lists, who are vulnerable. As you noted, people who aren't registered to vote, maybe teen mothers, homeless people, women without childcare or transportation, people without access to the internet, women who are vulnerable to sexual exploitation, abuse, and harassment. How can we ensure that these vulnerable groups are not left out? These are such important questions to think about as we move our plans forward. So thank you very much. And now I have the honor of introducing our keynote speaker, Ms. Karen Lucia S. Gomez Dumpit, the Commissioner of the Philippines Commission on Human Rights. Commissioner Karen has served the Philippine government for the past 30 years, 27 of which have been devoted to human rights advocacy, including 9 years as the first director of the Commission on Human Rights' Child Rights Center. A career executive service officer since 1998, her last post before her appointment as commissioner was a Director of Government Linkages Office. Since 2002, Commissioner Karen has implemented programs that carry out the constitutional mandate to monitor government compliance with human rights treaty obligations, harmonizing domestic laws in accordance with standards and principles set by core international human rights instruments, monitoring Philippine jurisprudence that affirm human rights treaties, and advising the executive and other relevant state agencies on their implementation of the obligations to respect, protect, and fulfill human rights. Commissioner Karen's inspirational leadership and work is unparalleled, and she will now be sharing key insights with us, focused on why meaningful representation and engagement of women in COVID-19 vaccine deployment, implementation, and monitoring will produce better vaccination outcomes for all. She'll also touch on the importance of the inclusion of marginalized and vulnerable populations in the vaccine rollout. Please join me in welcoming Commissioner Karen Dumpit Gomez.
A pleasant morning to everyone. Let me begin by acknowledging our co-conveners, UNFPA, and we welcome their new country representative, Dr. Leila Judan, USAID, World Health Organization, UNICEF, Philippine Disaster Resilience Foundation, Spark Foundation, and the University of the Philippines COVID-19 Task Force. It is an honor for the Commission to work with you in examining gender issues in the COVID-19 vaccination rollout. It has been a year since the world was forced to a standstill with the onslaught of this virus. Like most government agencies, we adapted to the situation to take care of our own employees and staff, so that we can continue to perform our mandate as the country's national human rights institution and the gender ombud under the Magna Carta of Women. The past year highlighted the importance of human rights in the COVID-19 response and the crucial role of developmental, humanitarian, and human rights organizations and institutions and civil society groups. We continued to work amidst the crisis, and our interventions and collaborations surfaced issues that are unaddressed or neglected. Over a year has passed since this public health crisis began, yet many issues persist. In recent days, we have seen high number of COVID cases that clearly shows the country's dire situation and the urgency of massive vaccination. The inequalities and gaps that the Commission has previously highlighted remained unaddressed. It is expected that these unaddressed inequalities and exclusions would impact vaccine rollout. It is in this light that the Commission continues to monitor the COVID-19 responses of government, using a human rights-based approach guided by the lessons from the past year. This webinar is an opportunity to reiterate and revisit our previous recommendations and renew our call for gender-responsive COVID interventions that also consider the realities of vulnerable sectors of society. This is embodied in the joint memorandum circular that we adopted with the Department of Interior and Local Government. We wish to reiterate the grounded recommendations of the Silayan report and the recommendations called from our community-based monitoring involving marginalized groups, including women with disabilities, women in detention, urban poor women, women fisherfolks, and women left behind by the war on drugs. In our joint memorandum circular with DILG, we called for gender-responsive COVID-19 interventions grounded on the lived realities of the people, especially the marginalized groups. This includes ensuring effective, prompt, and survivor-centered responses to gender-based violence. The COVID-19 pandemic compounds existing gender inequalities. It is expected to and has disproportionately increased women and girls' unpaid care work. It also heightened the risks of gender-based violence and sexual exploitation and abuse. Even as we move towards vaccination rollout, these concerns remain relevant. Over a year since the pandemic began, people's vulnerability and insecurity remain. With the economy not fully open and the high unemployment rate, the economic impact of the pandemic continues. Food security is still one of the top issues. Now that the COVID-19 vaccination program is being rolled out, we need to ask important questions to make sure that no one is left behind. Will those in the fringes be assured access to information, prioritization? Will measures consider their vulnerabilities? Will women and other marginalized groups be involved in planning and programming and in decision-making? Will gender-specific concerns such as maternal health, gender-based violence, and unpaid care work be considered in the vaccine rollout? As we continue to celebrate Women's Month, we highlight this important message. The way we honor women's courage and leadership during the pandemic is to ensure that women and girls in all their diversities be heard and be enabled to fully participate in the crafting of the government's recovery programs, including vaccine rollout. The way to honor women is to ensure that vaccine rollout plans are informed by women and girls' experiences, especially those belonging to the most vulnerable and marginalized. It is through the meaningful representation and engagement of women in COVID-19 vaccine deployment, implementation, and monitoring that we are able to ensure better vaccination outcomes for all. At this point, allow me to share some key findings of the Silayan report and the results of our sectoral monitoring with marginalized groups of women. A year ago, Silayan reported that vulnerable groups have been rendered more vulnerable by the crisis. Specifically, 60% of indigenous peoples, internally displaced persons, and urban poor women report not receiving ayuda or assistance from the government. It surfaced the exclusion of the so-called hidden households from government assistance. The sectoral monitoring of the Commission, particularly with women with disabilities, highlights how pre-existing communication and physical barriers were further exacerbated by the COVID-19 crisis. Medical and therapy needs of women with disabilities became even more inaccessible, and many members of their households were excluded from the government's list of beneficiaries. This sentiment was echoed by urban poor women, who, due to relocation and other housing-related issues, were also excluded in the list of beneficiaries in their respective localities. Women left behind by the war on drugs due to trauma and fear expressed hesitation in availing government programs and subsidies. Women in detention, including political prisoners, complained of isolation, the risk of infection, and limited supply of gender-specific needs. These are just some of the gaps identified a year ago and must be revisited to ensure that they are effectively taken into consideration and addressed during the vaccine rollout. The Commission reiterates its recommendation, especially to local government units, to address the access issues of the vulnerable and marginalized. The government must address with utmost urgency the needs of hidden households and beneficiaries. Government lists must reflect multiple vulnerabilities brought about by extended families and must identify those in need of care, such as children, older persons, persons with disability, and those who are ill. Considering that many vulnerable women, by virtue of specific contexts like displacement, homelessness, transients, are often not considered constituents, we recommend that efforts be undertaken to reach these women. These are culled from reports of exclusion from the government's social amelioration programs in the past year. Clearly, these issues must be addressed in the vaccine rollout. Vaccine information must be accessible for the deaf and other women with disability and those in geographically isolated and disadvantaged areas. Women's realities such as unpaid care work, distance to, safety and availability of transportation, and the risk of gender-based violence and sexual exploitation must be considered in vaccine programming. Sign language interpreters and translations of all vaccine-related issuances and announcements must be made available. Childcare support for women must be considered to allow them to travel to vaccination sites. Transportation support for women with disabilities and rural and indigenous women must also be provided. Gender-based violence must also be taken into account in the vaccine rollout. We put forth this strong recommendation in light of reports received through our GBV reporting portal and the findings in our continued monitoring of GBV cases, considering the so-called sex for quarantine pass practice during the lockdown and incidences of sexual harassment in security outposts and checkpoints. It is crucial that mechanisms be put in place to prevent gender-based violence as the vaccination progresses. This should include making available information on GBV and sexual exploitation, as well as complaint hotlines at every vaccination site. And where gender-based violence has occurred, access to justice and remedies must be available to victims. The Commission launched its Vaccine for All campaign, highlighting everyone's right to access COVID-19 vaccines, which are safe, effective, and based on application of best scientific developments. Vaccines must be accessible to everyone, especially for marginalized groups and people living in remote areas. We also highlighted the importance of accessibility and transparency of information about COVID-19 vaccines, including safety in relation to pregnant and lactating women, access to relevant and timely information, especially from government officials and health professionals, is crucial in ensuring proper decision-making. Participatory decision-making is also important. The most vulnerable and marginalized must be included in such processes and should be treated as stakeholders, rights holders, and not mere passive recipients of aid. In relation to vaccine delivery, we underscore the need for the government to be transparent, following appropriate criteria on the basis of medical needs and public health needs, always ensuring non-discrimination. We emphasize that the state must prioritize healthcare workers, those who work in the front lines, and persons vulnerable to becoming severely ill or dying because of age or pre-existing health conditions. We have stressed the need to prioritize those most exposed and vulnerable to the virus because of social determinants of health. We recommend that people living in informal settlements or in dense or unstable housing, people living in poverty, indigenous peoples, displaced persons, incarcerated people, persons with disability, and other marginalized and disadvantaged populations be included in the priority list. Let me end by stating that equality and non-discrimination must be mainstreamed in the COVID vaccination program. Gender is an important aspect in the access and prioritization discourse. However, it is not the sole consideration. Apart from gender, a truly inclusive vaccination program must take into account ethnicity, age, ability, religion, and other contexts, and the possible vulnerabilities that people experience because of one or more of these factors. I look forward to hearing the insights of our speakers today and wish all of us a fruitful exchange. Again, let me express the Commission's profound thanks to our co-conveners for this event, and we look forward to working with you building on the gains of our exchanges. Maraming salamat po sa inyong lahat.
Thank you so much, Commissioner Karen, for those insightful and important messages. I didn't mention this at the start of the panel, I should have, but one of the most exciting things about this event that has been organized this morning is the fact that we are going to be taking the key learnings and recommendations from this morning and compiling them into an LGU toolbox, which we're going to then disseminate to local government units throughout the country so that they can be thinking about these very important issues and vulnerabilities, best practices, and recommendations as they're rolling out their own vaccines in their own localities. So it's incredibly important that Commissioner Karen has just made so many very concrete recommendations that will help to address inequalities and to make sure that our vaccine rollout takes gender responsiveness as a backbone of everything that we're doing as we're rolling this out. I also really appreciated that Commissioner Karen pointed out that women are often highlighted as being a vulnerable group, but as she so rightly pointed out just now, it's not just women. We're not just a blanket group with the same needs. As she highlighted, there are women with disabilities, women who are incarcerated, women fisher folk women affected by the war on drugs, women in geographically isolated and disadvantaged areas, which of course will also need to be rolling out the vaccines, women who are vulnerable to gender-based violence, people living in poverty, the fact that women have unpaid work and how this is going to affect their ability to access the vaccines. As Commissioner Karen so rightly pointed out, we must ensure that the diverse entirety of women and girls are represented and have equal access to the vaccine. And she has called for the government to ensure that there is transparency and non-discrimination, because of course we're focused on women right now, but there are also other vulnerabilities that could affect how people are able to access the vaccine. So these are so important. Thank you for raising all of these points, Commissioner Karen, and these are great to have as additions, points that we'll be thinking about for the LGU toolbox, which I will talk about a little bit more later, because you in our audience are going to have an opportunity to be part of creating recommendations and best practices for that LGU toolbox as well. Of course, we cannot discuss COVID-19 and the vaccination rollout without hearing from a key stakeholder actor, the Department of Health. I now have the pleasure of introducing Dr. Norilyn Evangelista, MPM. Dr. Norilyn is currently Medical Officer 4 at Disease Prevention and Control Bureau at the Department of Health. Dr. Norilyn is trained as a physician and medical officer and is an established public health professional with expertise in a wide range of areas, including family medicine and community health, nephrology, multi-drug resistant tuberculosis and tuberculosis in children, HIV counseling, and much more. Recently, Dr. Evangelista trained in dengue surveillance with the National Environmental Agency in Singapore. Dr. Evangelista will be highlighting the Department of Health's plan to ensure gender equity and inclusion in the rollout of the vaccine. Please join me in welcoming Dr. Norilyn Evangelista.
Good morning, everyone. Magandang umaga po sa inyong lahat. On behalf of the Department of Health, we would like to thank you for this invitation. I will be presenting to you the COVID-19 vaccination roadmap. Next slide, please. Since we have initiated the Philippine National Deployment and Vaccination Rollout, of course, there exists a great number of timely and demand for timely and relevant information on the government's efforts to ensure that all Filipinos will be vaccinated. Okay, our vision is to provide safe, equitable, and cost-effective immunization to all Filipinos by 2023. And in order to achieve this, we need to establish sustainable immunization program against COVID-19 with the goal of protecting the public and reducing morbidity and mortality rates due to COVID-19. Next slide, please. The Department of Health's objectives for COVID-19 vaccination are as follows. First is to provide equitable access. To COVID-19 immunization services to priority groups, or at most 50 to 70 million Filipinos, if with enough global supply by 2021. Of course, due to the novelty of the vaccines, vaccine hesitancy is unavoidable. So we need to increase the demand for vaccination services through capacity and confidence building measures, ensure safety in the immunization program, and provide support to patients with adverse reactions, and to institute governance, regulatory, financing, and performance accountability measures for COVID-19 immunization. Next slide, please. All right, as shown in your screen is the organizational structure or the vaccine cluster governance. Okay, on top of it all, we have the Interagency Task Force on the Management of Emerging Diseases. So this IATF was created through Executive Order number 168, series of 2014. And then we have the National Task Force against COVID-19. This was established to oversee the operations of the national response. Okay? Under the National Task Force against COVID-19, it is further subdivided into the response cluster on the left side, the recovery cluster on the right side, and the COVID-19 vaccine cluster at its center. Okay? The COVID-19 vaccine cluster is divided into different subgroups. Okay, we have the task group on vaccine evaluation and selection. The lead is DOST. DFA is the one leading the task group on diplomatic engagement and negotiation. Task group on procurement and finance was headed by DOF, and DOH is the one leading task group on cold chain and logistics management and task group on immunization program. And lastly, the PCOO as the lead for our task group, demand generation and communications. Also, you can see on your screens that we have different independent bodies of experts. We have the vaccine expert panel, we have the HTAC or the Health Technology Assessment Committee. We have the NITAG or the Interim National Immunization Technical Advisory Group, and the NAFIC or the National Adverse Event Following Immunization Committee. So these independent bodies of experts, they are the ones providing recommendations to the IATF, making sure that all our decisions are based on scientific evidences. Next slide, please. Okay, let me walk you through the vaccination process. The Philippine National Vaccination and Deployment Plan is divided into two phases. We have the pre-implementation phase, okay, the preparatory activities for the pre-implementation phase, and the implementation activities. For the pre-implementation activities, we started with the identification of vaccine and eligible population. Of course, as I've mentioned, with the guidance of our independent bodies of experts, like for example, our vaccine expert panel. We have identification of simulation areas. What we did was we conducted code visits or the coordinated response to defeat the epidemic. We conducted LGU visits. We tried to check their micro plans, the readiness of the LGU with the arrival of the vaccines in terms of manpower, cold chain, and also we conducted tabletop exercises with scripted injects, okay, to challenge their micro plans. If they have prepared contingency plans, for example, in terms of cold chain for the vaccines. Next, we have the 3 M's, the master listing, the micro planning, and the mapping, okay? The master listing and the micro planning are all LGU led, and the mapping of COVID-19 referral hospitals, okay? We instructed the LGUs that part of their readiness assessment tool is that they already map out all the level 3, level 2 hospitals within the catchment area so that they already know where to refer the patient in terms of adverse event following immunization. As what I've mentioned earlier, we are currently on our implementation phase. We have started our vaccine administration. And after this vaccine administration, we have the post-vaccination monitoring, wherein we will monitor the vaccinees for adverse events following immunization. And we have the expert panel, group of body overseeing this, the NAFIC, or the National Adverse Event Following Immunization Committee. Next slide, please. Okay, just to show you that we ensure that the vaccines are of good quality, safe and effective. This is the process on the procurement of the vaccines. Okay, the World Health Organization highlighted the need to have an expedited regulatory approval for pathway for COVID-19 vaccines. Okay. Correspondingly, the government issued Executive Order number 121, which gives FDA the authority to issue the emergency use authorization. Okay? The emergency use authorization, or the EUA, is not equivalent to the certificate of product registration, but we still make sure that the benefits will outweigh the risks. Acknowledging this, the FDA issued later the FDA Circular number 2020-036, or the guidelines in the issuance of emergency use authorization. Next slide, please. Okay, with the passage of our Universal Healthcare Act, or RA 11223, DOH can procure new technologies with the positive recommendations from the Health Technology Assessment Committee. Okay, I've mentioned earlier that the HTAC, or the Health Technology Assessment Committee, is one of the independent expert bodies. So as shown in your screen is the decision matrix that needs to be complied in order to have the positive recommendation from HTAC, or Health Technology Assessment Committee. Next slide, please. So where are we right now? The picture that you're seeing on your screens right now are the preparations that we conducted for the arrival of the vaccine. So like what I've mentioned, we conducted LGU visits. Here are some of the LGUs that we have visited. And also, we have visited the cold storage facilities in preparation for the arrival of the vaccines. Next slide. Okay. I'll be presenting to you the prioritization criteria, or the prioritization framework. The prioritization framework for our COVID-19 vaccination was upon the guidance of World Health Organization SAGE, or Strategic Advisory Group of Experts on Immunization, and also upon the recommendation of our independent expert bodies, such as the NITAG and the TAG, the recommendations to the IATF. And the IATF adopted these recommendations through the IATF resolution number 98. Okay, so these prioritization are anchored on the following principles. Of course, for our A1 are the frontline workers. The following principles are as follows. Number one, human well-being, where health, social, and economic security, human rights, and civil liberties of all citizens and individuals are promoted and protected. Second, equal respect, where all human beings are treated equally and their interests are considered with equal moral consideration. Third, national equity, where equity in vaccine access is assured nationally and those with greater burden of COVID-19 pandemic. Reciprocity, where all individuals and groups who bore a greater burden in the COVID-19 pandemic response and have higher significant risks brought by their responsibilities and roles shall be given greater priority. And lastly, legitimacy, where decisions are made through transparent processes based on shared values and scientific evidence. Next slide, please. Just to reiterate, the independent groups of experts, the NITAG, the TAG, the Vaccine Expert Panel, and the HTAC. As a woman, I'm proud to share that the NITAG is being led by one of the strongest women I know, Yusek Maria Rosario Vergeri, and the vaccine rollout and field implementation is being led by one of the key leaders in the National Vaccine Deployment Plan, Yusek Mirna Kabutahe. So the DOH, ever since the promulgation of RA 9710 Magna Carta for Women, has also institutionalized gender and development in all its policy formulation and implementation, from offices, hospitals, down to the barangay health centers in the community. Next slide, please. I've mentioned earlier that there will be a post vaccination monitoring. Okay, so as shown in your screens right now is the AEFI, or adverse event following immunization surveillance cycle. So with the guidance of WHO, we have this vaccine surveillance with the goal of early detection and appropriate and timely response to adverse events in order to lessen the negative impact on the health of individuals and on the vaccination program. So the AEFI and identification and reporting of facilities are all outlined in Administrative Order number 2016-0006. So the minor adverse events following immunization cases are to be reported weekly. And the serious AEFIs and clusters of minor AEFIs are to be reported within 24 to 48 hours immediately. And case investigation shall be performed within 24 to 48 hours. Next slide, please. So these are just the preparations for the AEFI surveillance. We have cascaded training modules on AEFI, so adverse event following immunization. We have conducted trainings on the VigiFlow. Of course, right now, with the advancements in technology and innovations, they have created a different platform for the data management and on the monitoring of vaccine surveillance, the VigiFlow app, and also ensuring the functionality of our regional AEFI committees and regional AEFI response capacity. And we have finalized the referral pathways in the regions. Next slide, please. So we can all be champions of vaccination. Let us be agents of tamang informasyon or correct information. We share accurate information. We take active steps to be informed. We organize sessions to engage others constructively. So thank you very much for inviting us for this webinar. We join DOH organized or DOH partners sponsor the webinars. We participate in feedback forums to report fake news. So these can be debunked, and we answer surveys and participate in FGDs. Next slide, please. We have the power to change other people's opinions because you are the champions. We are the country's champions. Let 2021 be the best year. So BIDA is part of our advocacies. B for bawal ang walang mask and face shields. So we need to wear our mask and face shields. I, isanitize ang kamay at iwasan ang mga kulog na lugar. We need to wash our hands, sanitize our hands. D for dumistansya ng 1 metro at limitahan yung physical na interaction for physical distancing. A, alamin ang tamang impormasyon. So we need to prevent yung mga misinformation and disinformation. Next slide, please. So let's be the plus solution laban sa COVID-19. For the plus, we support the FDA-approved COVID-19 vaccines. Next slide. Okay, that's the end of my presentation. Again, thank you very much and good morning.
Thank you so much, Dr. Norlin, for your presentation. I really learned a lot. It's especially reassuring to me to know that the Department of Health has vaccine surveillance plans in place to ensure that any negative impacts of the vaccine are minimized. I personally am a public health person and I believe in vaccines, and I've been urging all my friends and family and colleagues to take the vaccine if it's offered to them. But as has been noted, and I think will also be discussed further, vaccines right now are being rolled out amidst a very high level of vaccine hesitancy among Filipinos. Studies are showing that only about 30% of people polled are saying that they want to take the vaccine. And the majority of those 30% are men. So we need to really get at, why are women hesitant to accept a vaccine? What are their unique concerns? What are they scared of? And we need to make sure that these gendered concerns, once we identify them, are addressed when we have DOH representatives, barangay health workers, different all the different bureaus that are working on this. They need to make sure to address these things when they're giving out the information and conducting information, education, and communication campaigns. So thank you again, Dr. Norlin. These are very important topics to tackle to ensure that the best vaccine rollout and uptake is possible for Filipinos. Thank you so much again. Before we continue, I just wanted to tell you a little bit more information. I'm seeing in the chat box some questions, so I'll give you more information about the toolbox that I mentioned earlier. The toolbox is going to have policy templates in it, tools and strategies for operationalizing the best practices, and even video for orientation to ensure that everything is very well understood. This will be shared widely with many different actors. And if you want to be sure that you get it and you're not sure that you might send us a message in the chat so that maybe we can compile your email addresses. But this will be shared widely, and there will also be direct implementation of the toolbox in select LGUs around the country. So we're also seeing now that there are some questions coming in. Thank you very much for those. We will do our best to address those and pose those to some of our resource speakers. If you have questions for the speakers and panelists and you have not yet put them in the chat box, please do consider using that. And as much as possible, please make your questions concise and direct. And if you have a specific question for a specific panelist as they are presenting, please make sure to include them in the question so that we can address it to them. So with that, the first kind of section of our presentations has concluded. So thank you once again to our speakers. We've learned so much already. So I'd like to thank again Ms. Michelle, Dr. Leila, Commissioner Karen, and Dr. Norlin for highlighting the key strategic issues and concerns, and for setting the stage for the discussion of our resource panel that we're now going to have. I'm really excited about this next part. I think this is going to be fantastic to hear from the expert panels that we've put together. So I now have the honor to introduce our panelist resource speakers who will be tackling the issues already raised and discussing them in further detail in the context of the work that they each carry out. We're going to begin now with Mr. Alexander Smith, Gender Advisor, Maternal and Child Health and Nutrition with USAID Washington. Mr. Alex will be highlighting the U.S. experience in vaccination rollout, especially addressing challenges in making vaccines more accessible and equitable to marginalized sectors. He'll also directly address and identify Southeast Asia risk mitigation strategies. Mr. Alex is in Rome, where I believe it's around 3 in the morning right now. So he has sent a video, which we are now going to show for you. So welcome to Mr. Alex Smith.
Good morning, everyone. I'm Alex Smith. I'm a USAID Senior Gender Advisor in Global Health. covering maternal and child health and nutrition and infectious disease. Thank you very much to the mission for inviting me to talk to everyone today about gender and vaccination rollout and the challenges in making vaccines more accessible and equitable to marginalized sectors. I'll be discussing some of the common gender barriers to vaccination rollout and some of the potential barriers specific to the Philippines based on past immunization programs. USAID is currently drafting program guidance on COVID vaccines, so keep an eye out for that. And I'll be talking about some of the guiding principles we'll need to keep in mind as USAID eventually provides program guidance for missions. And then finally, I'll address some of the concerns about vaccination programs and sexual exploitation and abuse, the risk mitigation strategies, and the recently published USAID policy and toolkit. First thing, I want to make a quick comment about the U.S. commitment to combating COVID-19. The pandemic has caused the deaths of 1.8 million people globally and disrupted the health and economic well-being of billions more around the world. COVID-19 vaccines will, of course, play a pivotal role in mitigating and controlling the pandemic and reducing the loss of life and severe illness in the U.S. and abroad. USAID brings critical technical expertise through its highly skilled personnel and its technical assistance mechanisms. Which are beneficial to ensure COVID-19 vaccines are accessible and equitable to marginalized sectors. Vaccinating populations also offers an opportunity to support primary healthcare systems and structures to build health systems resilience going forward. In non-COVID times, immunization is foundational to a primary healthcare system and is one of the best buys for investments in global health. While we've seen tremendous progress, still about 20 million infants per year are still not fully immunized, sometimes because of gender barriers. Also important to keep in mind, this COVID-19 vaccine rollout is unique in the sense that the pandemic has altered the landscape for all immunization and other health interventions. While some countries have partially recovered from initial disruptions, the pandemic has exacerbated a lot of social and economic divides, as well as gender inequalities, particularly those related to multiple burdens of caretaking. As we know, women make up an outsized share of our frontline workers. Women face historic levels of unemployment and are disproportionately shouldering an increased caregiving burden and responsibilities created by the pandemic. There are also biological gender differences in COVID-19's susceptibility, incidence, severity, and mortality rates. On December 27th last year, Congress appropriated $4 billion to prepare for, and respond to COVID-19, including for vaccine procurement and delivery. The $4 billion will support efforts to provide access to vaccines for the 92 low and middle income and lower income countries in the world. Just a few weeks ago, the White House issued a message announcing the creation of the White House Gender Policy Council, affirming a government-wide approach to gender equity and equality. The Council is committed to discovering why some segments of populations are disproportionately not receiving the vaccine and how USAID can find remedies that are more inclusive and equitable. Now, I'd like to discuss the vaccination rollout and some of the challenges in making vaccines more accessible and equitable to marginalized sectors. There are barriers, including gender, that apply to all immunization programs, not just COVID-19. Gender inequality based in underlying power relations and restrictive gender norms is, of course, a key determinant of health and well-being. Gender also contributes to the demand for access to and use of health services, and consequently has significant implications for immunization coverage, particularly for the hardest to reach populations. Though immunization is one of the greatest public health successes, some challenges remain. For example, coverage rates for diphtheria, tetanus, and pertussis vaccine have plateaued over the past decade at about 85%. Peer-reviewed publications and gray literature related to gender and immunization programming show that a lot of the analysis of gender programming and immunization has focused on sex differentials in immunization coverage between boys and girls, and how broader aspects of gender inequality are associated with child immunization overall. Aspects like mother's education and socioeconomic status, women's agency and empowerment. This is defined as decision-making and the ability to act on those decisions has been found to be a predictor of immunization coverage. Another is male engagement in immunization programs. It's not been documented and is often not considered in program design, and yet we know that male engagement has an effect on a lot of other health programs. There's not a lot of research on the possible link between GBV and immunization coverage. For example, whether access to vaccination centers may be impeded by unsafe travel or unsafe facilities. This is noteworthy because mistreatment during maternal, newborn, and child health visits has been widely documented as a deterrent from care, any kind of mistreatment or violence. And studies correlate this kind of abuse with mothers' decisions to bring their children for vaccine services or not. There's not a lot of research on this, but there is some inference that mothers' decisions are affected. Other gender-related barriers to vaccination, these are barriers commonly cited by partners like Gavi, include cultural practices that may prevent female caregivers from seeking immunization services from male health workers. Caregivers may lack information and awareness on the benefits of vaccination. There could be low socioeconomic status of caregivers or lack of women's access to household funds that limit indirect costs of vaccination, things like travel. Long wait times or limited hours at clinics, caregivers' income-generating activities. Traveling long distances to health clinics may deter women, particularly young mothers, from bringing children for immunization. Negative attitudes from health workers, service providers may discourage caregivers from return visits to complete their immunization schedules. In the Philippines specifically, one study on lessons learned found some strong achievements, such as the establishment of a national program for immunization and the eradication of polio and maternal and neonatal tetanus. But critical challenges to immunization were also flagged. Specifically, these were vaccine stockouts, strong anti-vaccination opposition from advocacy groups, and public awareness of the controversy around Dengvaxia. For anybody who's unfamiliar, this was a health scare in the Philippines a few years ago caused when dengue fever vaccine, Dengvaxia, was found to increase the risk of disease severity for some of the people who received it. Data suggests vaccine confidence has begun to improve since then, but to maintain that progress, researchers stress the importance of strong partnership between health leaders and local communities, keeping cultural factors in mind, engaging with multidisciplinary stakeholders, and strengthening public health infrastructure for the COVID-19 vaccine. Other solutions and best practices from the region suggest that attention must be given to developing and implementing vaccine tracking to develop a vaccine distribution plan in line with the established delivery strategies and the appropriate reverse logistics and vital retrieval plans and accountability plans are in place. Gender-specific best practices include gender analysis in the interests of understanding and addressing gender-related barriers, ensuring that men, women, girls, and boys have equal access to vaccines in the strategies, and ensuring that gender and cultural barriers are considered in personal hiring stages, meaning, having women or men doing the vaccinations where appropriate or where culturally accepted, gender equity and safe monitoring and response, and gender program data disaggregation and analysis at all stages. As of 2021, there's a burgeoning effort across international organizations and the global immunization partners to support action on gender and immunization. For example, Gavi has planned a series of learning sessions on gender and immunization and established a multi-agency group on gender. Gavi is also adapting the George Washington University's Gender Pro capacity building and credentialing program as a staff training specifically for gender and immunization, and they'll be using that to train all staff. Here I wanted to just briefly highlight USAID's Gender Integration Continuum. This is our approach to integrating gender into any kind of a program. This is a conceptual framework that illustrates the different approaches to gender integration, from exploitative to accommodating to transformative, and all of their potential consequences, with the ultimate goal of gender equality and better development outcomes. Simply put, exploitative means actually making worse or reinforcing gender inequalities. Accommodating means working around existing inequalities. And gender transformative meaning addressing root causes of gender inequalities while at the same time supporting positive program outcomes. An example of a accommodating program might be, if travel is the main barrier why women or children can't get to vaccines, accommodating would mean bringing the vaccines to the people, whereas gender transformative might be addressing the root cause of why women are not able to travel, if it's because of economic reasons or if it's because of GBV concerns or something else, or household decision making about travel. A gender transformative program would seek to address those root causes. Good, and finally, I wanted to talk about the issue of sexual exploitation and abuse and risk mitigation strategies. This is something that we should be considering anytime aid workers, including active partners, are coming into contact with communities. USAID has thousands of career staff and roughly 4,000 active partners in more than 100 countries. Last year, USAID published the first policy on protection from sexual exploitation and abuse that applies to all of those active partners and staff. A few key definitions in the policy. Sexual exploitation is any actual or attempted abuse by aid workers of a person in a position of relative vulnerability for sexual purposes, including profiting monetarily, socially, or politically. Sexual abuse is any actual or threatened physical intrusion of a sexual nature, whether by force or under unequal or coercive conditions. USAID takes a survivor-centered approach to SEA allegations, meaning the survivor's experiences, considerations, and needs are at the center of the process. When the survivor is a child, the approach must be in the best interest of the child and engage with the family and caregivers as appropriate. Preventing and responding to sexual exploitation and abuse, USAID focuses on 3 mutually reinforcing objectives. These are educating and empowering USAID staff, changing how we do business, and holding each other accountable. And the policy seeks to improve performance in addressing sexual exploitation and abuse allegations to ensure timely and consistent responses, also to improve communication and engagement with populations we serve, and to reduce incidents significantly over the long term. Just quickly, this policy makes clear that all USAID staff have a responsibility to prevent and address sexual exploitation and abuse and US-funded assistance. However, the responsibility is particularly significant for agreement and contracting officers and their respective agreement and contracting officer representatives, the AORs and CORs. They provide direct oversight to implementing partners. The second objective, this means about changing business, how business is done, means identifying and understanding the risk factors early in the core business process, and also considering country context, strengthening efforts in prevention and monitoring, and building on existing mitigation strategies and response mechanisms. And then finally, the third one, holding each other accountable, means that reporting and investigating all credible allegations actually happens. And I'll post this link to the tools that are available. There's a prevention from sexual exploitation and abuse toolkit on the USAID website. And I'll also include, just so that you have it, the complaints and reports, anonymous hotline information. There's a website and telephone number and an email. Great. That's everything from me. I look forward to hearing from you all. If you have any questions, I'll leave my email on this last slide here. And I appreciate the invite, and I look forward to hearing more about your work in the Philippines. Thank you very much, and have a good day.
Okay. Thank you so much to Mr. Alex Smith for sending us that video and some very important points that he raised, things that we can learn from, particularly about the gendered impacts of COVID-19 and gender-related barriers to vaccination. Before we go on to our next speaker, we have noted that there are a few questions for DOH, and we do know that Dr. Norilyn, unfortunately, is not going to be able to stay for the whole morning. So we wanted to ask her a couple of these questions before she has to go. So Dr. Norilyn, there were some questions in the chat box for the DOH for you to try to address. I'm just going to read 2 of them now. There's a third one we'll ask if we still have time. The first is a question from Reggie Salonga of the GAD office of Muntinlupa City. Is it possible to prioritize the vaccination of the populations where there are high numbers of cases, rather than distributing the limited vaccines in all areas of the country? So that's the first question. And the second is from Libby of Oxfam Global Humanitarian Team. I'd like to understand how these hidden households will be able to proactively access the vaccine, since we know they can be missed in the listing of priority groups. For example, indigents, the usual way of being included in the indigency listing at barangay level may exclude a teenage mom or a woman who may be in jail or may not fit the higher risk group. So yun po, how can the hidden households, the people who are more vulnerable, proactively access the vaccine? So Dr. Norilyn, if you're able to please turn on your... Okay, sige po. Thank you.
For the first question about the access, about the
Yes.
framework, about the prioritization. So,
yeah.
okay po. Let me just reiterate that yung the prioritization framework po was upon the guidance of WHO SAGE and anchored po on the principles that I've mentioned. But we also included those yung sa mga GIDA po in our sub-prioritization. Department of Health issued po different guidelines. First on the prioritization framework and yung mga sub-prioritization framework wherein we consider po yung mga high burden areas. Over to you po.
Okay po. Any advice po for that second question of if someone may be one of those described as hidden household na baka wala po sila sa listahan, or is there something that they can do? Can they identify themselves somehow? I mean, of course, this isn't ideal if they're vulnerable to place the extra onus on them, but the question specifically was if somebody could proactively access the vaccine.
Okay po. So, like what I've mentioned po kanina, the 3 M's are microplanning, the master listing, and the mapping of the COVID-19 referral hospitals are all LGU-led. So, we followed po the bottom-up strategy. So, meaning po, all these lists po are coming from the LGUs. But I'm so happy to be a part of this webinar because the inputs, the questions that you have provided serves as an eye-opener pa rin po that we need to recalibrate our policies to include po everyone, making sure that nobody is left behind.
Okay, maraming salamat po. And just briefly, there was one more question. I'm not 100% sure if I understand it exactly, but from Miss Emily Torculas, is there any plan to have a vaccine program where NGOs can access aside from that of the government? Miss Emily, I'm not sure if that means a vaccine program where NGOs can help give out the vaccines, or if you're asking if NGOs can access vaccines like government workers. But Dr. Norilyn, if you know the answer to either of those perspectives, if you could share.
Okay po. So with the directive po, or for directive of President Duterte, we will provide equal access po to all Filipinos in terms of the COVID-19 vaccination. Okay. So with regards to the procurement of the vaccines, it is stipulated in the EUA po, like what I've mentioned, with the passage of Executive Order 121 po, we have the emergency use authorization wherein President Duterte gave the authorization to FDA to issue these EUA to COVID-19 vaccines. It is included in one of the provisions that for example, LGUs, NGOs, or private companies, they can procure vaccine as long as they will enter into a tripartite agreement with the national government, and they will comply or follow the prioritization framework set forth by the national government.
Okay. Thank you. Miss Emily did clarify she meant access, so I hope that has been helpful. So thank you so much again, Dr. Norilyn, for joining us, for being here this morning. I'm really glad to hear that that these questions that we're tackling now will be addressed further. We're tackling them here because they're hard. They're hard questions. It's hard to figure out exactly how to ensure that we are minimizing the risks and that we can have the best possible rollout possible. So maraming salamat po ulit.
Maraming salamat po. Thank you po.
Okay. So we're now going to go back to our to our speakers for our panel. And I now have the pleasure of introducing to you an esteemed democracy activist, a human rights champion who has worked for decades on social justice issues, the most well-known of which was the fight for land rights of the Sumilao farmers, where he marched from Bukidnon to Manila side by side with his fellow human rights defender, now Governor Arlene Caca Bagao. Mr. Josel Gonzalez is Chief of Staff in the Office of the Governor in Northern Mindanao province of Dinagat Islands. He will be discussing their plans for gender equity and inclusion and highlight operational challenges and issues facing LGUs, especially those covering rural and high poverty municipalities with many infrastructure challenges. So we're certainly going to be learning a lot. So please join me in welcoming Mr. Josel Gonzalez, Chief of Staff of Governor Arlene Bagao of Dinagat Islands. Sir, the floor is yours.
Thank you very much. First of all, I would like to thank the organizers of this roundtable discussion for giving us the opportunity to share our experience here in Dinagat Islands. Oftentimes when we talk about Dinagat Islands, the first question that people would ask is, where is Dinagat Island? So let me introduce our province by introducing our more and better known neighbors. We are on the north side tip of our island province is Giwan, Eastern Samar, in the island of Homonhon. And on the southern tip of our province is the more popular tourist destination, Siargao Islands. So Dinagat Island is in the northeasternmost tip of Mindanao by the Pacific Ocean. Dinagat Islands is one of the newest provinces in the Philippines. It was created only in 2007, but actually it operated as a province only in 2012 after the legal complications and the legal issues about its creation as a province was resolved by the Supreme Court. We only had 3 governors, and perhaps Dinagat Islands holds the distinction of being the only province in the Philippines that has not experienced being governed by a male governor, as all the 3 governors in the history of our province were female governors, from Jade Ecleo to Governor Glenda Ecleo, and now Governor Caca Bagao. We have a land area of about 1 million square kilometers and a population of barely 127 to 130,000 people. We are a 4th-class province. So you can imagine the poverty of our province. And perhaps also, I would like to discuss together with me today. I have brought a reinforcement from our provincial health office, our provincial health officer, Dr. Jillian Francis Lee. She's beside me. She is a graduate of the DTTB program, and she has been working with us. She stayed on with Dinagat province after she graduated from the DTTB program last year, serving in one of the smallest municipalities in our province. Next slide, please. First of all, because we're talking about COVID, let me give you an overview of the statistics of COVID in Dinagat Islands. We fended off COVID-19 infection from February, actually February to August 2020. We had 0 cases in the span of those 6 months. We only had our first confirmed case in September when the government brought back LSIs, facilitated the return of the LSIs to their home provinces. So that was when we first experienced our first confirmed cases of COVID-19. So all in all, we have 126 confirmed cases up to yesterday. Up to yesterday, we have 126 confirmed cases, 5 of which are active. 3 of them are in the hospital in Surigao City, while 2 of them are in the hospital in Surigao City, while 3 of them are in our provincial care and containment center at our provincial capital. 121 of the confirmed positive were recovered. Next slide, please. In terms of geographical distribution, the most number of cases are in the capital town of San Jose, and the second highest number of cases are in Cagjanao, and mostly a huge bulk of these confirmed cases in Cagjanao came from the mining areas there in the 3 barangays. So, and there are and in other municipalities like Loreto. It was only in November that we detected a spike in our cases that is indicative of local or community transmission, because there are cases that of people who had no travel history outside the province. So we implemented granular or localized community quarantine so that we can contain the spread of the infection to the other areas in our province. Next slide, please. So as you can see in the graph, this is the timeline of the COVID infection. Our infections peaked in late November or mid-November until December. This was a time when people began to come back home for the Christmas holidays. This was also the time when the schools in Surigao City declared that they will be holding online classes anymore, and they stopped doing face-to-face classes because of the local transmission in Surigao City. So when students came back, many of them were infected by COVID-19. Of the 7 municipalities, 5 have cases that are indicative of local transmission. And in December, by mid-December last year, which saddened most people because it was Christmas time, we declared a lockdown of our borders. We only allowed exit of people, of residents, but we did not allow the entry of people, so that our containment centers will not be overwhelmed by the number of positive cases. Next slide, please. When Dinagat Islands faced COVID-19 last March, with the beginning of COVID in February and March last year, it was very clear to us that we cannot afford to have an outbreak in Dinagat, primarily because of 3 major reasons. Number 1, Dinagat is a 4th-class province, and therefore our internal revenue allotment was very, very limited. We have a 20% development fund that is only around 300 million. So therefore, we cannot afford the implications of having an outbreak in Dinagat Islands. Our municipalities are also not that rich. We have 1 municipality that is 3rd class. We have 3 municipalities that are 4th class, And there are three municipalities that are fifth class, almost the lowest in the classification of our local government units. We have very limited resources, and we cannot, like many, unlike many more local government units that has bigger internal revenue allotment, we cannot afford to feed people, to give unlimited relief goods to our people. Next slide, please. Likewise, our facilities for health are also very inadequate and limited. Dinagat has only 3 infirmary level district hospitals with a total of 16 doctors, but I was updated by Dr. Jillian. We already have 20 doctors as of today in the provincial and municipal governments. And we have to thank the Department of Health for this, because six of these doctors are doctors to the barrios, and some of the doctors are have graduated, are scholars of the provincial government, and they have returned to give service to our province, to our province. So the doctor to patient ratio is 1 doctor for every 8,000 persons, 8,000 persons in the population. That is a far cry from the ideal of 1 doctor for every 1,000 population. Next slide, please. As you may all see, Dinagat is a province that is very poor. The provincial government is a 4th-class municipalities. We have, according to the DSWD, we have a poverty incidence of 50%, which includes 12,000 households. Majority of our population are either farmers or fisher folk or both. Because we were declared as a mining reservation, land ownership is almost impossible in the Dinagat Islands, because the lands are classified as mineral lands and not therefore A&D lands. Around 90% of the land in Dinagat Islands is being claimed by mining companies or under the MPSA of 19 mining companies. So you can imagine the poverty of the people, and if you restrict the movement of people, farmers and fisherfolk, they would be very severely affected by the restrictions in movements and in travel, because their products cannot be moved, their products cannot be sent outside the province, which are their traditional markets. Next slide, please. That is why our tagline for our COVID response has always been our communities, our front lines. What does it mean? It means that this strategy involves a defensive social perimeter in its values, in its boundaries. That is what other people call now a bubble. So Dinagat Island, we declared Dinagat Island as an island province bubble way back in March 2020, where we do not allow people to enter Dinagat Islands without undergoing a 14-day quarantine. We view the pandemic not only as a crisis in health, but also has deep economic and social impacts on the population, especially the poor. We have our COVID-19 responses has always been rights-based and humane, including the enforcement of health protocols. We never view the enforcement of health protocols as a peace and order problem. Therefore, we do not have any arrests, unlike in other places. We do not have arrest of citizens violating these protocols. COVID-19 responses also, we all involved all the stakeholders, government agencies, both local and national government agencies who are based here in the Dinagat Islands, civil society organizations, and different interest groups within the province. In the spirit of communities, our communities are front lines, local communities were viewed not as victims of the pandemic, but rather as citizens who are our first line of defense. Our frontliners are not just the health workers working in our health facilities or working as law enforcers. Our frontliners include the farmers, the fisher folk, women who keep our economy afloat, who keep our social life in the island almost normal. So what we did with Dinagat Island is we restricted entry into our boundaries, and we allow people to have more freedom of movement within the boundaries, so that our economic activities are not affected gravely by the restrictions. Next slide, please. So the key elements of our response to the threat of the pandemic, number one is timely and preemptive response. As early as February of 2020, even before the Philippines has declared its first confirmed case, we already started discussion and building our health protocols. We started by monitoring the entry and exit of people in the islands. And we also started to build our infrastructure in relation to the municipal governments in the province, and our relationship and structures in relation to our regional offices, which is Caraga. Next slide, please. Our health and medical professionals played a vital role in developing our health protocols. We did not believe in tuog-tuog. We did not believe in many other myths that involve the antibody testing. So our health professionals provided us with scientific and expert opinions in our development of our health protocol. And fourth, which is one of the main pillar of our COVID protocol, is care and containment. Because we required everyone who enters our province to undergo 14-day quarantine. From the provincial down to the municipal level, we established containment care and containment facilities, otherwise known as quarantine facilities, so that people will be isolated during their 14 days quarantine. Later on, we even included agency containment centers for the national government, national line agencies. Next slide, please. Because we view the pandemic not only as a health crisis, but also a crisis that has deep economic and social social implications, we provided emergency employment for women and persons with organizations of people with persons with disabilities. We engaged them in the production of face masks that were used to that we distribute freely for free to our population. We provided them with capital so that they can produce face masks and other PPEs. Next slide. Because of the restriction of the movement of our fishery products from their traditional markets like Leyte, Surigao City, Butuan City, and the rest of the provinces in Caraga, we had to provide an alternative. So first, what we did was to provide subsidies for the fishery products by the marginal and artisanal fisher folks. These are fisher folks who are able to catch about between 5 to 10 kilos per day of fish in one fishing outing. We provided a 30 peso subsidy for the consumers so that we can ensure that the prices of our fish products are stable and affordable, so that the market, the local market of our fish products are also stable and strong. This provided continuing income for our marginal fisher folks and their families. It also benefited not only the fisher folks, the consumers, but also the market vendors who were organized. Next slide. Because we are an island province, and traditionally we were very dependent on mainland Mindanao for our for different food items, we had to ensure that our province will not run out of food, and also to ensure that our farming families and our ordinary families have enough food and income. Our provincial government, instead of giving out relief packs, which would last a family only 1 week at the most, we provided them with seeds of vegetables that they can grow in their garden, in their backyard. So we distributed vegetable seeds so that every household has vegetable to plant. They can harvest after around 30 days or so. We distributed around 9 types of vegetable seeds together with fertilizers. Next slide. And because of the travel restrictions and the restrictions in the places that are our traditional markets for our agricultural and fisheries products, we had to establish an alternative market. So we hold the tabo sa Kapitolyo, or the market day, for our farmers and fisher folks and other people who have produced have local products like candies, biscuits, bags, and many more. We also provide, so every Thursday we have this market day in our provincial capital, where literal in Bisaya, in tabo is the literal translation of tabo, which is a word in Bisaya, is convergence or a gathering. So Tabo is a gathering of all the producers and in the market. So we had a market in our provincial capital once a week, so that they will be able to sell all their produce and all their products to a captured market, which is the provincial capital employees and the consumers in the provincial capital